All right, we'll get started here. Dr. Mo, can you hear us?
Yes, I can.
Okay, good. Welcome to Stigma Reduction. Reduction, sorry. Just want a reminder, if you have a question, please raise your hand. We'll get you a microphone so everybody can hear. If you need the CEU credits, there's a link on the Whova app. And for those who are virtual, please put any questions or comments you have in the chat or in the Q&A. So without further ado, Dr. Mo, go ahead.
Thank you very much. So I'm going to start with full transparency. I am teaching in Honolulu, Hawaii this summer. And so I am single momming it. So I am presenting with a 5-year-old today, and there is a possibility that there could be some questions that she has during this presentation. So please bear with me if that does arise, although we saved tablet time just for this event. So hopefully all will go well, but I wanted to be transparent. So again, my name is Dr. Melissa Dipperner. Lots of people know me or call me Dr. Mo. I am a person in long-term recovery, and today I'm presenting twice, and I'm going to talk about really stigma in both of those areas, but in a little different light, and how we can be supportive. But for this talk, we're going to talk about how we can decrease stigma around addiction. We know that one of the biggest reasons that people don't come forward with their addiction, or sometimes can't tackle what their addiction looks like, or even be able to navigate through addiction, is because there is this stigma around it. And so I want to talk today with all of you in an interactive way about what we can do to be on the forefront of helping others in this area, and just being more aware of our words, what we say, what we do, and how we can impact people just by the way we speak to them, just by the words that we use and the actions that we have surrounding addiction. And some of those, sometimes we may not fully understand how we think about it or how we talk about addiction and mental health until we take some time to internally look, until we're called out on our words that are harmful, and until we really take the time to move forward and be able to navigate what that looks like. So I feel like slides never work when they're supposed to, but here we go. So my objectives for you today are really just to be able to avoid words and be able to certain words and be able to change them for other words. And obviously this is a practice not unlike any other, where once we're aware of it, it does take some time for us to shift and adjust to that. So if you've been using the word addict or clean or commit suicide, it's going to take you a little while to change those things, and that's okay, but it's about catching yourself and understanding how powerful words can be and then moving on. So what I really want you to do is be able to share these things with a colleague or a friend and be able to say like, hey, that's maybe not the appropriate terminology, and let's try and use a person in long-term recovery, or let's try to use a person struggling with addiction or impacted by addiction or something to that effect. So that's really, we're going to talk further about that. But that's really what I want you to do, is be able to share it with other people, because once we can teach something, we know that we've learned it, or we're in the process of learning it. And that's really what I wish for you today, after you're done listening to me chat or us chat together. And then I want you to be able to discuss treatment options or different treatment options with a colleague or a friend or someone else surrounding addiction and what it could look like. I still feel like there's so much stigma around medical assisted treatment and being able to use harm reduction strategies in order to help people navigate their addiction. And today I want you to be able to communicate what that looks like too. And I guess what I want you to understand, and you probably already do, is that addiction is a disease of the brain. So people come at me when I say this, and that's fine. And we've all heard this, and a lot of you probably already know this, but saying like, well, it's willpower. And yes, there is a portion of willpower, and I won't discredit that, but it is also, once you've tried it, which people are apt to try drugs, right? We're on this mission of telling people that, drugs aren't bad in every situation, but we do need to be in a space where we can be safe, that our doctor knows that we're using them, or at least a friend or family member. We don't go alone. We have the tools to help us if we need. But there are a lot of people that endeavor for a lot of different reasons, right? And we know that as we're going through these periods of our life. And so what we really want people to do is be educated about what drug use can look like, and what does addiction look like once it takes over. So nobody wakes up in the morning and is like, I'm going to have a beer today and tomorrow and the next day and the next day, and then I'm going to drive drunk and kill someone. No one wakes up with that thought pattern, right? But obviously we know that these things do happen and that we need to be aware of what it looks like once it's in an addiction space. So reminding everyone that addiction is a disease of the brain. So I say this often, and I really feel like the opposite of addiction is not sobriety. And we'll talk more about what that looks like. And if that's offensive to you, I want you to think about why that maybe strikes you. But it really is support and being able to be supported along your healing journey. Again, as I told you, I'm in Honolulu. And as I've been talking to people that are here that are in the addiction space, they're telling me that it's not just your recovery in terms like we may use it in the Midwest, but it's really our healing journey and how that ebbs and flows. And so I've kind of been trying to adopt that because honestly, it makes more sense to me. But again, if you feel like sobriety is the only answer to addiction, I want you to think about that. I want to challenge that thought for you today. And I want to challenge that thought for you based on research and based on information surrounding harm reduction and even best practices from SAMHSA. So first, we're going to dig into stigmas here a little bit. So we're looking at this public stigma. So this idea that the general population has surrounding addiction, and what does it look like? As I'm traveling around, driving the streets, kind of getting to know my new area here, I'm seeing people who are struggling with houselessness. And my brain doesn't first go to, what got them there. I'm like, what happened to you, right? What happened to you to get you into that space if you don't want to be there? And then what does it look like for mental health and addiction? And how much does that play a role? But is that everybody's idea when they see somebody who's struggling with houselessness? Is that everybody's idea when they see somebody who's clearly struggling with an addiction issue? Not really. We've kind of put this, people are bad, they're not worthy, they don't have any willpower, they don't, sometimes people even think that they're not worthy of treatment, that they're kind of a lost cause. And I do understand that, addiction does present itself as poor behavior often, amongst a couple of other things that present like that. And because of that, it's really hard to understand why somebody you love unconditionally and are trying to get help would steal from you, or would hurt you, or would do any other thing that somebody struggling with an active addiction would do, right? So I do get that, but at the same time, we have to take this public idea, which is why I speak about stigma, and say that addiction does happen, and it happens to anyone. It doesn't pick certain people to happen to. And sometimes it can be, somebody who's very affluent and struggles with addiction and you never quite know until it gets too extreme, or it could be something that you can see a little bit more closely. And it is maybe somebody who's struggling with poverty, they kind of wear that addiction on their sleeve per se. But when we shun those people, when we don't help those people, honestly, it hurts all of us. And if you think about it in terms of how much does it cost for ER visits, how much does it cost to take care of these people one way or another, we do, right? And we should. And what does that look like? So I challenge you again to think about, what are your public stigmas? If you look at somebody and you think, they're struggling with addiction, even though you're in the field, it's okay to have that initial, wow, that's a lot kind of thought. But then what do you do with those thoughts afterwards? If you say, this person, I don't know if I can deal with this person, take some time to think about, what does that look like? Why? What happened to you that might put you in that space? Well, how does that trigger you? Or where do those thoughts come from? When I work with students, oftentimes they really tell me that those thoughts come from their parents, which is neither here nor there. But I want you to think for your own, is obviously what I tell them. And I want you to take the time to really understand, what does it look like for you? What does it look like for you to have thoughts around those different spaces? Where do those stigmas come from? And how can you navigate forward? You can always have thoughts come in, right? They can flush in and they can even be bad thoughts, but it's acting on those. And how do you act on those thoughts? And what do you portray when you do unintentionally or intentionally act on some of those thoughts? So I ask you to think about those things for yourself. And then we're going to move on to the self-stigma. So this is internalizing what it looks like to be, and I'm going to use some terminology that I wouldn't normally use, but to be an addict or a junkie, right? So we have these terms that we use that are quite punishing, really. I feel a little gross even saying those. And when we use those terms, we ourselves even. So thinking about myself, as I first got into recovery, I used to call myself a junkie. I used to call myself an addict. I used to call myself, clean, which I'm not clean nor dirty. I'm a human, right? Like I took a shower today. Of course I'm clean. So using those terms is not appropriate, but I thought I had to call myself those things in order to get to a space where I could better myself, where I could work towards self-actualization. But really what I was doing was kind of death by 1,000 cuts, right? Every time I said it, I'm like, ugh, I don't feel that. Ugh, I don't like that, and it made me kind of just ball up a little bit smaller, a little bit more enclosed, a little bit more isolated. And really what I think I was doing was harming myself over and over and over again in a way that was not helping me grow. And so when I decided I wasn't going to call myself any of those things anymore, and I was going to advocate for this new terminology that I was learning, I saw myself kind of expand again and kind of blossom into this, oh, I'm not this thing. I'm not an addict. I'm not a junkie. I'm a person who struggled with addiction until I got the right help that I needed, until I got, to a space where I could heal along my healing journey. I struggled, and that's okay, and fortunately, I had a wonderful support group, and I'll talk about what that looked like a little bit, that helped me navigate this process and helped me get to the next space. But that self-stigma moves into label avoidance. So we have somebody, let's go back to the affluent person. We have somebody who's struggling, who feels like they shouldn't be struggling because they have maybe everything going for them. And they're not going to reach out to get help because they're terrified of what it might look like to have this label put on them. And so they avoid getting the help that they need. And sometimes that harms other people. And so we really need to look at, what does it look like when we use this public stigma? How does that curve over into self-stigma and label avoidance? And how can we start to break down some of these walls? So I guess I challenge you with that question, and you're welcome to put in the chat or even open up in session there if you'd like, about how do we use our skills that we have and the things that we know to break some of this label avoidance. So I feel like as people reach out to me and say, hey, my so-and-so is struggling and I don't know what to do. How can I help them? What does this look like? I don't know if it's this self-stigma or this label avoidance or something else that, comes into play, but I know that people are not reaching out for help when we want them to. And I feel like some of these stigma pieces come into play. So if anybody wants to jump in and maybe answer some of those questions, what do we do to help break down these stigmas? What can we do to decrease label avoidance and self-stigma? How do we let people who are impacted by addiction, that they don't have to stigmatize themselves? And I'll be quiet for a second to allow people to answer if they so choose. Okay, well, I ask that you swirl that around in your head and get back to me if you feel like you have some answers for those questions. So some of the ideas that I have, we'll move forward here. And I'm sorry, the screen is the words are a little small. I really need to revamp this, and I apologize. So words to avoid, I'm not going to read you the whole list because you can read, and you can also find this uploaded in the Whova app. So I feel confident that you can reach back out if you need some of these notes. So looking at, again, I said addict, and I know a lot of people, I listen to a lot of comedians, I listen to a lot of people who speak on podcasts about addiction. I listen to all these spaces of people still using the word addict. And I understand that it's a word that we've used for a very long time, but we've changed in other areas. And I know that we can change in this area too. And I think because I have changed that terminology for myself, and as I said, that I'm aware of what it looks like to stigmatize other people, I kind of cringe when I hear this word now. Not saying I don't accidentally use it every now and then, just saying it doesn't make me feel comfortable anymore. So I say that to say, please think about what that looks like. A person with substance use disorder, a person with alcohol use disorder, a person with opioid use disorder, a person with eating disorder. Just that person first language is really what we need, right? If you were a person who struggled with multiple sclerosis, you wouldn't be MS, right? You would say that you were a person with multiple sclerosis, right? You're living with it. It's not who you are. And people are not a drug addict. They are not a junkie. They are not an addict. So think about changing that to that person first language. And this isn't new. We've heard this for forever. And honestly, it kind of makes me sad that I have to keep repeating this because we're not kind of like getting on the ball. Like I even hear this when I work with people who have been in the field for a long time. And I know old habits are hard to break, but it's absolutely worth breaking them. And it's absolutely worth you being an advocate for what that change looks like, especially if you know someone, love someone, or work with someone who struggles in these ways. It's absolutely worth it to make these changes. So clean and dirty, abstinent or using, it's just as easy as that. when you're talking about a person's use, or you're talking about them or talking about a drug screen. And then again, recovery, it could be recovery journey, long-term recovery, it could be healing journey, it can be whatever that makes it a little less stigmatizing. And then when we're talking about, medications for opioid use disorder or medications for addiction treatment, things like that, there's different ways for us to say that. And I think the one that hurts my heart the most is committed suicide. And I know, again, this is a terminology that we've used a lot, but they didn't commit anything. They either completed it, they died by suicide, they killed themselves, something that doesn't stigmatize a person who has completed suicide. So just a few to think about, and we're going to kind of move on here. So the next thing I want to talk about is SBIRT. So SBIRT is screening, brief intervention, and referral to treatment. And I feel like a lot of people that I talk to probably already know what this is today, but a lot of people that I talk to really don't quite understand how to have these conversations. And so we're going to run through, not really SBIRT, but I want to talk to you about what it looks like to have these hard conversations. The first time somebody ever reached out to me and said they were in the process of killing themselves, that they had taken a handful of pills and they needed my help, was probably the hardest thing that I've ever had to deal with to date, because I didn't feel like I didn't have the skills to deal with that, but it felt very unfamiliar to me. Of course, they didn't come out and say that at first. I kind of had to dig that out of them, right, in order to get them the emergency care that they needed. And since I've came across a lot of people who are suicidal, and it took, somebody, me, asking them the question, are you thinking about harming yourself? Do you have the means to harm yourself? What does it look like to keep you safe? And those things are really difficult to say out loud. And I think that medical professionals often find that talking about addiction or even drug and alcohol use is really hard for them to talk about as well. And so this SBIRT can really help people kind of navigate that process and what it looks like to be able to put SBIRT into really anywhere first line help. We think about people who are struggling with addiction and mental health needs, and sometimes all they need is that one support person, the one person to ask them, are you okay? Can I help you? What do you need? Did something happen to you? What can we do? Right. And I tell, especially med students, if someone comes into you to get care and they're presuming because of Western medicine that they'll be getting some sort of medication to help with whatever their problem is, and you don't ask them about their alcohol or drug use, how are you doing the best by your patient that you can? If you're potentially going to prescribe them something that could interact with what they're already using daily, especially if it's, mass quantities of alcohol or drugs, then you're not doing the best by them that you can. And I think that really shocks med students because they don't think about it in that way, but they still find that they're uncomfortable, even at the highest level of med students, as they're going out into the field. They find that it's very uncomfortable. So the screening can really help. It just asks a very low amount of questions. Do you use alcohol? Do you use drugs? Is it this risky level? And then we can kind of move on after that, right? So it does take out some of the hard questions. It's right there on the screening for them, whether it's on a tablet or a pre-screening before they come in, or whether it's a sheet of paper with just a couple questions on it. And then you kind of have a little backbone to go, okay, it shows on this that maybe you are at a risky level. Can we talk about what that might look like? That brief intervention. And then if they, come back to you and say, yeah, I am drinking like 8 beers a day and have been for the last right? So then we can get them referral to that treatment. And we're very lucky in South Dakota. We have lots of resources. I've done a lot of research in other states, and not every state has as many amazing resources as we do. But, I tell them, reach out to 211-988 if it's serious, figure out what they need and find those resources for them. Moving along this path for what it looks like for SBIRT. So if you are feeling uncomfortable asking some of these questions, making sure that you're using some of those intakes and screenings to better understand what it looks like to help them move forward. And some of the screenings that are in there, and the link is in there too, so you can have it, obviously not off the screen, but in the Hoover app as well. But that pre-screen, the audit, the mass, and the PHQ. So just to give you a better idea of what those screenings look like inside of that SBIRT. And if you have more questions about it, there's a lot of people who are like SBIRT experts, I would say, in the surrounding area. So please reach out to me for anything really, but reach out to me if you have more questions about that, and I can connect you with somebody that I feel like is an expert in that field. So, okay, it's okay. It's okay. All right, like I said. So I want to talk a little bit about my story and just a smidge here, kind of talk about what it looks like to break through that stigma and to have that support and kind of to move forward, and how, being able to have people with me on my path was really what helped me stay where I am. And so I am a high school dropout. I dropped out in ninth grade, struggling after a parents' divorce, and really got into drugs kind of accidentally, to be honest with you. I kind of hung out with all the other kids who were maybe going through divorce and kind of had like a rougher time. And I had smoked weed a couple of times, but never really, like, not a lot. And I remember my friend handed me a tin foil and said, just inhale it, just inhale it. And I, being a person who really had a wonderful life until my parents got a divorce, never thought that anybody would try and hurt me, and not that they were, but even give me something or do something that might harm me. And I really honestly didn't even ask what it was until after I had already done it. So I had DARE. So I had the training in fifth grade about what it looked like for drugs, but it didn't look like anything that DARE taught me. So it didn't really speak to me that I was doing something that might harm me. I remember having a couple of beers that night and then not being able to sleep for, what seemed like 24 hours. And so that really was the start. And if I'm looking back today, that is the start of what got me to do exactly what I'm doing today, because I feel like having the information, having the education about what addiction looks like and what drugs look like and how to be safe and how to make safe choices, I really wasn't, again, taught that like people would do bad things, or like bad things could happen to me, or like any of those things. And not that I think that my parents sheltered me, but I feel like I didn't get the information that I could have had surrounding drugs that could have kept me safe in that area. And really, we know about meth, and we know that meth is a super dopamine drop. And for a kid that's never had a dopamine drop like that, it was huge. It was huge for me, and it felt great, and it took away a lot of the pain. It felt like a warm hug, right? And so that just started to snowball of not great things, one after another, after another, after another. And I struggled for a few years with the use of uppers. And so I got myself to a space where I was in recovery from methamphetamine use, and I have been for over 20 years now, which is super cool. But what I didn't do was deal with how my brain works, or what addiction looks like, or what I needed, or some of that healing from maybe my childhood or other traumas or things like that. And so I stayed away from drugs for a long time, but what happened was it moved into the next thing. And I found alcohol when I was like 25 or 26, being that comfort, feeling like that warm hug. And it went really from just the same, just a couple of drinks with some friends, to holy cow, I'm really overdoing this in a space that is very dangerous for me. I was fortunate enough to be part of a roller derby team, which was super fun, but they were, they helped me drink a little bit too much, but they also helped me get onto a path of recovery. They were, we'd go after the game, we would go to the bar to celebrate our game and with our opponents, and just have a good time. And I always had someone that was like, hey, if you're going to be sober tonight, I'm going to stay sober with you. And I have so much gratitude for that, because I had a full team of people that were my support. And so I'm now over 12 years, almost 13 years, alcohol free. And so I know that support was the starting for what it looked like. There was no judgment. And now, after becoming a researcher, getting my PhD and understanding even more, I realize where that support really comes in. And so that's why I say truly that the opposite of addiction is not sobriety, but that it's support, because I've watched it not only work for myself, which is great. That's my lens, right? Like I get to have that. But then now I have the research and understanding to say that, oh, this is what works, whether it's the Rat Park experiment, whether it's just understanding peer supports and what peer supports look like, or whether it's understanding, that human connection. And so, again, I'm super grateful that I had what that looked like in order to get myself into a safe space. And at one point along my journey, I was working as a welder, and I was actually fired, which is, I'm not really proud to say that. A lot of this story I'm not really proud to say, but I feel like it takes vulnerability from people like me to be able to talk about what's happened, to help other people who might be struggling and know that it is hard, but you can get to that next space. But I was fired from my job as a welder, and it was the best day of my life, honestly. I skipped out of there with my welding helmet and I went home to spend time with my kids. And I was so happy, but I also knew that I didn't know what I was going to do next. I was a single mom with two very young children. And now I didn't have a job. I decided that I was going to get my GED after being out of school for, I don't know, maybe 10 years at that point, and really only making it to ninth grade. So I really didn't have a ton of education, if you will. And so it took me about a month to get my GED because, let's be honest, math is hard. And so I got my GED, and I moved on to USD, and I've been at USD ever since 2008. I've been at USD since 2008, whether it was getting my bachelor's degree in addiction studies, my master's degree in addiction studies, or my PhD in human development and educational psychology. And I'm so grateful that I did. But what pushed me was to be able to reach people. When I got fired, I reached out to a prevention place and said, hey, I've struggled with addiction. I've loved someone with addiction. I would love to tell people what it looks like so they can stay safe. And they were just like, nah, I mean, cool, but like, here's like some people you can talk to, but really like, we don't want you unless you have any education. So that really was what pushed me, not only to stay in a space where I was safe, but to go and get some education so I could help people. And now I get to do things like today, where I hope I'm helping people, or at least giving you some insight into what addiction can look like from a personal view and an educational piece. And I feel really grateful that I can do that. I just did a TED Talk a couple months ago, and although it was probably one of the coolest things I've done, it was so hard. I felt so vulnerable. And I'm going to talk about it in the next presentation that I have at 3:30. But it made me feel, some type of vulnerability that I never thought I could feel. I shared a story about myself drinking too much, being stigmatized, and then just being in the spotlight like that in a space where, that doesn't come down, and TED Talk stays up forever, and hopefully it goes viral so that way I can help other people. But it felt very vulnerable for me to be in that space. And I had to kind of fight with that a little bit and say, okay, this was the thing you wanted to do because you want to be able to help people and advocate. You want to be able to support people and educate them. And so that's how you got to this space. So don't look back now, even though it's not perfect. I will never claim that TED Talk is perfect. I was very thrown back by the audience laughing at my joke. First of all, I'm not very funny, so that was fabulous. And second of all, when I asked, is there anyone that's currently struggling or personally impacted by addiction, is the term that I used. And almost the whole audience, which was over 100 people or right at 100 people, raised their hand. And I was taken back in a way that I did not expect. I know that addiction impacts everyone. I do, but not always on a personal level like that. And so normally when I ask that in an audience, I get maybe, 10 hands up that are willing to share that. But that night in that space, under those extremely bright lights, there was almost everyone in the audience who had been personally impacted by addiction. And it really threw me off. And I didn't expect that. And I didn't expect it to take me to a space where I was going internally instead of externally being in my surroundings. And so I love that moment. And I love that I'm able to do that. And I suggest to other people that are maybe in recovery to see what your advocacy could look like, whether it's talking to one person, sharing your story, becoming a peer support, whether it's just navigating that process in any way. There's a lot of healing that comes with being able to share your story and know that you impact people. I think every time I've ever spoke, someone has reached out to me and said, hey man, I dig what you're sharing. I'm really proud of you, or this really helped me, or thank you. I now understand what my father had went through and he's since passed away. And now I have some healing. And that is so powerful. And honestly, I could almost cry at the fact that I get to be able to be that for others. And that feels really good for me. So I share my story, not because I'm like, oh, look at me, or I'm like, oh man, look what I did. None of those feelings I hope to bring out, but what I hope to bring is I can do this. I understand this. I can advocate for this. I can help people educate for this. I can support other people. That's really what I hope to bring out when I talk about my story. So we're going to go back to harm reduction and what it looks like. So harm reduction is just really this set of strategies that people use to help other people. So I really don't even like the term harm reduction. I would call these common sense practices. When the only way we really use harm reduction is people who use drugs. And so I feel like it's unfair to take another thing and call it almost something bad, like drugs don't always have to be bad, right? When we use medication for opioid use disorder, those drugs are not bad. If someone is using marijuana with their medical card that they were prescribed by a medical doctor, that is not bad, right? Drugs don't have to be bad. They tend to get a bad rap, that's for sure. And they do impact people very poorly if they struggle with addiction. So again, harm reduction is this common sense practice for helping keep people safe. And we know that you can't tell someone to get into recovery. We can't drag someone, we can't fight someone, we can't, and sometimes we can, but it is really hard. They really have to be in a space where they're ready to make that change, because that's where the bit of willpower part comes in. And I'm not going to say you have to hit rock bottom, because I don't totally believe that. I do think that an event oftentimes does slingshot people into getting into their recovery or starting their healing journey. But I don't think that is the end all be all of what happens. But we can't make them do things like that, right? But we can keep them safe along their journey. So that can look like a ton of different things that we're going to look at. But thinking about things that we can help when we're talking about harm reduction, it could be HIV, it can be AIDS, it could be hepatitis C. It could be, when we talk about medical assisted treatment, I think it says on here, the needle programs people are 5 times more likely to enter treatment and 3 times more likely to stop using drugs than people who don't have these programs. So why is that? Well, they have the support, right? They have the people there when they go in to get clean needles, or they're going in to get clean whatever, right? They have people that say, hey, if today's the day, I'm here for you. If you need resources, if you need help, today's the day and I can get it for you, right? And some people might say, nope, today's not the day and I'll see you later, right? But those people are 5 times more likely to actually get that help because they know where to get it in a space where they are not stigmatized. With almost certainty, I can say that people who work in clean needle programs and other harm reduction spaces are not stigmatizing them, right? They are there to say, hey, we want to keep you alive. Here's a can of Narcan to keep you alive. Give it to your friends, keep it on your person in case you overdose, keep yourself safe, right? So there are tons of different things. So let's just move to the slide so I can stop kind of beating around the bush here. Safe injection sites, which we talked about, and hopefully someday we'll be able to see one of these up close and personal in South Dakota. I saw that Minnesota just passed theirs, and that is amazing. They've been doing some great things in the world of harm reduction in Minnesota and North Dakota, which surrounding us makes me think that, hey, someday we'll do this too. We have had some good wins in South Dakota. The last legislative session, fentanyl testing strips went from being illegal as paraphernalia to being legal to be distributed and to be used. So fentanyl testing strips and even xylazine testing strips, sorry, I'm so used to saying fentanyl, are basically just a strip that you can use to test your drugs. You need a small portion of your drugs and you can test it to make sure that you're not getting fentanyl. I'm again, with almost all certainty, knowing that people are not testing their drugs to make sure it is fentanyl. Which is some of the feedback that I get sometimes. Are they testing to make sure it's fentanyl? Are we boosting fentanyl use? No. People who use other drugs don't want fentanyl, mostly because it kills a lot of people and it's super dangerous. They're trying to make sure that that's not in their drugs. And xylazine has reached South Dakota. So if you've not heard about it, it is a horse tranquilizer, I believe. It is Narcan resistant. It acts a lot like more powerful fentanyl. And it is extremely dangerous. I think we've even had our first overdose case in South Dakota. And if somebody wants to correct me on that, I'm happy to be corrected. But I think that's what I heard while I've been here. So in the last 3 weeks. So we definitely want to make sure that we are being careful about what that looks like, getting people the testing strips that they need. And I work with Angela Kennecke at Emily's Hope. I'm on the board of directors, and we are going to be handing out fentanyl testing strips in South Dakota and the Sioux Falls area. So also, if you have ideas of where these testing strips should be or places that need them, or if you need them yourself that you could hand out at your organization, please, please, please reach out to me and we can make those connections. We want to make sure that these testing strips are getting in the hands of people that need them. So again, we talk about pharmacotherapy, so that medical assisted treatment, being able to get people the treatment that they need when they need it and as they need it, right? So I know that this is a huge thing that I'm going to get really passionate about, because we are not tackling this correctly in Sioux Falls. And I know that I may be extending my reach here and maybe even angering people on accident, but that is not my goal. I am a harm reductionist and I am people first. And I've been hearing things where people are not getting the medical assisted treatment that they need. And if we think about humans just as the biopsychosocial model, right? So we think about that biology piece. If they've been in active addiction, if they've been using a drug that starts to change their brain, we need to, or they could possibly benefit from drugs that help them get back to a safer space, right? We are not changing one drug for another. We are treating a disease. And we really have to remember that as people who potentially, possibly, I'm guessing, work with people in addiction, we have to advocate for that too. We need it in our jails. We need it in our prisons. We need it utilized at the link. We need it in the ERs and everywhere else that we can get it. We have medical assisted spaces in South Dakota, and the people are great. Dr. Ball, Dr. Tumang, Pam Van Meteren, those people know what they're doing and they know how to help people with what they need as they're struggling with addiction. We really need to utilize those spaces and be able to get people the help that they need with their medical assisted treatment. So in terms of stigma, we have to break the stigma around using medicine to help people get to a space where they can be healing. When we look at the Good Samaritan laws, that's educating people about what a Good Samaritan law looks like. So quick story, I was in Norfolk, Nebraska, talking at a alternative school, and I'll never forget this girl. I was teaching them about the Good Samaritan laws in Nebraska, and her friend had just died of a fentanyl overdose. And she had the longest eyelashes I've ever seen, and she was a beautiful young lady. And she looked me dead in the eyes and said, You mean I could have saved my friend? So she's sitting on trial to go to prison because her friend died while she was there of a fentanyl overdose. And so we really have to educate people, especially young people, about what Good Samaritan laws look like, being able to let them know that it is okay to get people help. We don't allow people to die because they're dying of a drug overdose. We have to let people know that they can get the help that they need. And I know for people who may, have run-ins with the law or be able, not want to deal with law enforcement, we still have to let them know that it's the right thing to do no matter what. And there are protections in place. Sometimes people do get arrested when they turn things in, but we can't allow people to die in those spaces. And I will forever advocate that, especially after that young girl. And then, kind of slingshotting with Narcan, that young lady also didn't know that Narcan was available, that they could and should have had Narcan on them, and that she could have saved her friend in that way because she did die of a fentanyl poisoning. So things for us to think about, treatment instead of jail. Are we helping people when they send them to jail or prison? Are we just teaching them to be a prisoner when they go to prison instead of how to navigate their addiction issues? Overdose education. I mean, I let people know. I spoke in a very small town in South Dakota not too long ago, and I asked them, I told them first, my message about drug use is not dare. It's not don't do it, because I know that kids will. And I'm active and understanding because I deal with college students all the time. I have my own kids. I see things. I research things. I know that people do things. And so telling them if they are going to use, here's how you can be safe. Make sure that you don't use alone. Go slow. Have Narcan. Let people know what's going on. Don't use alone, right? There's things that we can do to make ourselves or help people who are using drugs to stay safe. And we have to get them that education, whether it's about, overdose education, what overdose looks like. What if your friend sounds like they're just maybe snoring, but they're kind of breathing a little bit shallow. What is that? Is that overdose? Yes, it absolutely possibly could be if you can't wake them up, right? If they're foaming at the mouth, these things are things that kids may not know because they've not been in contact with it. And my college students don't know it too. So when I say kids, I was talking to junior high. No, I was talking to 5th grade through 12th grade. They were young. And I didn't really want to have those conversations with them because I felt, dang it, you're young. But they've been exposed to it. They knew what I was talking about. They understood, and they took in that information, right? So we as parents, especially, have to talk to our kids about it. Even though we look at our kids and we look at them as babies, right? We still have to have these hard conversations with them. So it doesn't take them learning it in the hard way, because maybe your little Johnny or your little Susie or whatever might not be the one who uses a drug, but maybe their friend Sarah is, or their friend Tim is, and your kid is going to have to save this other kid, right? We don't want to put them in any sort of predicament where they couldn't be able to handle what that could look like. And I think teaching them that isn't terrible, right? Like if we know they're going to be potentially impacted by what addiction looks like in some way, let's teach them about what it could look like, and then hope they never have to deal with it. We learn CPR and we hope we never ever have to use it, right? The same thing with opioid overdoses, the same thing with all of that, right? So other harm reduction techniques are this individualized care. Being able, when we say we got to be able to reach people where they're at. Cool. What does that mean? How do we do that? How do you let people know that they are people, right? If you use the same paperwork every time and you talk about the same stuff every time, how are you letting people know that they're getting individualized care? How are you making their care individualized for them? Because we talk about it a lot. But how are we doing it? How do we make sure we do it? What does it look like to get the care team involved? Do you even have a care team for your individuals? What does this look like? And then lastly, wound care, thinking specifically about people who maybe are homeless. So what does that look like? How do we get them wound care to stop from other infections, other diseases, or being able to, if somebody is an injection user, being able to make sure that they get the support that they need. And another harm reduction technique is peer support, right? So on the screen, you see, I'm not going to read these to you or go through every one. But if you don't know what a peer support is someone who has lived experience and training to help people navigate on their healing journey, right? So I am a peer support. I got trained to be a peer support, and I'm actively doing peer support work as we speak. So it's just being able to utilize my unique experience as a person who struggled with methamphetamine use, alcohol use, overworking, eating issues, all the things that make me, right? Who struggled with all that. And then how can I use that totally wild and unique story, my life, my past, to help other people navigate where they want to get their healing journey? And peer supports are pretty awesome because they can be part of a care team. They can help people along their journey at any stop along the way. The minute they decide they need help, you could get a peer support and have them be with you along that journey and long into extended recovery and aftercare, which we all know that we need support in those areas. We don't have enough aftercare to keep people, on their journey. What if they just like, oh, today is the day I might step off my path a little bit, and they could go, hey, Dr. Mo, I'm feeling a little wild today. Can we sit down and have some time to talk about this today? I really don't want to fall off this path. But I'm having some thoughts they're kind of pushing me that way, right? But if you don't have support, or you're isolated because of stigma or whatever reason, you don't have the availability to reach out to that. And if you're feeling weak in that moment, or you're feeling like you just aren't ready to, reach out to someone, being able to have a peer support in that way is very powerful. So in 2021, a bill was approached that is supposed to go through nationally for peer supports, hopefully sometime soon. I think it's still sitting for Medicaid and Medicare reimbursement. So we're really hoping that can happen to help reach people in that way. Now peer supports are self-pay, although Face It Together, I think, is funded through the state. So there's services there. They're doing amazing things there. And there are peer supports. I guess maybe I should talk about this. Peer supports are not just people in long-term recovery from addiction. It's also mental health, or people who love someone who struggle with addiction, right? So there's ways to get help in all of those areas, because as a person who struggled with addiction, the hardest thing I've ever done is love someone who struggled with addiction. That was way harder than navigating my own process of addiction. And I think people who might be in that unique position like me might also agree with that. It's really hard to know, are you loving someone? Are you enabling them? And what can that look like? So being able to have that support as you're waiting and wishing and loving someone to get the help that they need, being able to have someone support you so you're not accidentally enabling them, because that can happen, right? We could say, oh, I love them, and oh man, they lost their apartment, so I'm going to send them $1,000. so they can get a new apartment. Well, is that $1,000 going where it needs to? When you could just say, hey, when you find your next apartment, let me know, I'll send that $1,000 for your apartment, right? Just little things like that we can shift, you can still love them, and you very much should, and you can still support them, but you're not accidentally enabling them. So there's space for that too. And I don't think that people understand that they've loved someone, that they are uniquely qualified to be someone who can support other people along this path. Because as my research shows, 100% of people will come in contact with people who struggle with addiction and mental health issues. And we need to be able to know what it's like to help them, to navigate with them. And so I think that's all I have to say about peer supports. I could talk forever and ever about this, but I think it is a very important piece of the puzzle. And I think that it needs to be more widely spread, more widely talked about. I know that there's lots of us working in South Dakota to get things going there. And in my next talk, I'll talk more about what we've been doing for grant programs. And I posted in the Whova app about if you want to become a peer specialist right now, Straight Up Care, which is the company that I'm the CEO of, we are giving out free or grants for people to be involved and become a peer support if they so choose. We want to break down every barrier that we can. And again, I'll talk more about that in my next session if you're there. But if you have any questions, you're able to reach out. And I put peer support grant in the Whova app, so you can find it that way too. If you have any questions, you're welcome to reach out to me. So I really think that's all that I kind of have to say. I wanted to leave some time for questions, but what I'll leave you with is please make sure you watch your words. Make sure that you're not harming others with them. I think I never really understood how impactful words can be until I started speaking. And I realized that the words that I say could accidentally harm other people as I'm speaking. And I hope that I didn't do that today to any of you. I get very passionate about this field, this topic, these areas, the people. I love people. And so I get a little wild and crazy as far as my passion and my compassion for others. But I hope that I inspired you to do the same. So now I'd love to open this up for questions, if there are any.
One question here, 1 second.
Thank you for your talk today. I work at Avere Behavioral Health, and I make follow-up calls after individuals have screened using SBIRT in the local emergency departments. And so with that, for example, the other day I had a challenging conversation where somebody was very upset because I was asking about substance use. So that situation, I tried to validate and kind of redirect and say, you know, if you want to focus on mental health right now, I absolutely understand that. That one didn't have a great outcome, did a welfare check and things like that. But I just want to know in general, kind of what your suggestion is on bringing up substance use when we are trying to help somebody. So, for example, some of my community health worker cases do have meth use history, and in some situations I make calls and I can tell that they're actively using based on speech and things like that. Do you think there's benefit to kind of addressing that and asking about those things, or is it better to just try and work on whatever needs they present and let them bring those issues to me?
Hey, that's a wonderful question. And I think you tackled that as well as you could, right? Saying, hey, this is the thing, you know, this is something I'd like to ask you or talk to you about. And I think always bringing up the conversation is good. And there are times where they're combative. And I think one thing that you can say back to that is, this is common practice. We talk to everyone about this, even if you don't. I think there are spaces where it's okay to fib if you're trying to help someone. But I think it's okay to say, you know, these are the types of questions that we ask people to make sure that they're safe. If it's not a concern of yours, it's okay to say that. I'm not trying to upset you or, you know, make you feel in any way. But I think you tackled that very well. And I think you're extremely right that, you know, some of those conversations do get unhappy. And I think that's almost a telltale sign that maybe something is going on. I also think, and if anybody in the audience has any more suggestions, I'd like you to add after I finish my last thought here. I do think it's okay to keep asking those questions, keep being there. And especially, I can tell by the tone of your voice that you are a compassionate person, right? So almost done, sweetie. So being able to say that, you know, I'm asking because I care. This is part of what we do. If you need anything, just let me know. I'm going to ask you again, just letting them know kind of what the process might look like. And they can get a little feisty with you. I'm sure you have a little thick skin too. And then kind of move on from there, right? Let them know that you just care. And that's the reason that you're asking. That would be my advice. But I would like to open that up to anybody else to add any experiences that they've had or any other advice that they would give, please.
Any responses? Here's one.
Actually, it's not a response, but it's a question if I can move on, if that's okay.
Yeah, totally fine.
Dr. Mo, thank you very much. I have a comment and then a question. First of all, I'm glad you raised the challenge with regard to the terminology of harm reduction. It is somewhat of an odd terminology, and I'm with SAMHSA, and I'm, as a federal official, I'm the one actually challenging our own terminology, but it is really health promotion. And I think it's another way to kind of think about this in a very solution-focused, health-focused kind of way, as opposed to kind of emphasizing kind of the negativity, as you kind of pointed out. The question I have, though, is I wonder if you can kind of talk a little bit about how do you frame the commentary that addiction treatment or substance use disorder treatment is effective with your clients and families? Because we're finding that that is a really key type of part of the conversation that we don't do good enough on, is how do we talk about treatment being effective?
It's hard because if we look at, this is hard to say, but if we look at the numbers of how many people do stay in sobriety or long-term recovery after treatment, they're not great. So this is a hard question to answer, but thank you for bringing it up. So it is hard to bring up that conversation, but it is a starting piece. And I think that any sort of support, any sort of understanding, any sort of education is a great first place for people to go. And treatment is successful for people. So I feel like, again, there's a lot of stigma around even treatment and what it looks like, even though we've been doing it for forever. I feel like it's just breaking some of those stigmas around that conversation too, about what treatment does for people, what it's there for, and then finding the right one. And I guess if I'm being fully honest, I would say that maybe some of the treatment programs just don't match the people. And that's why we don't have as high a success rate as we would really like to have. And we know that, aftercare is something that we need, but we're not quite implementing the way we need to. And I think we're all in agreement that we kind of need to shake up the way that we treat addiction and how it needs to be a more long-term care process. But I think telling them, if we find the right treatment center and find the right care team that people need, that it really can be successful, breaking down those stigmas, letting them know that, this happens to people and it's not a bad thing, and just kind of giving them some of that support around it, I think would be my answer for that. But I would also open that up to other people as well. Also, thank you for challenging that at the top. I appreciate that.
I guess a question I have is that seeing people in mental health counseling, that I oftentimes see them engage in substances for the undealt with trauma.
Mhm.
And, sometimes I wonder, what is it better to deal with the trauma and as well as because to me it's kind of like you're treating the symptom versus the cause. And I'm wondering, how do you see that fitting in?
Yeah, I feel like we could talk about trauma for a whole nother hour. But I think if we look at co-occurring and best practices for co-occurring, talking mental health and addiction, and I feel like trauma could fit into both of those categories, I think that we have to tackle both at the same time. We have to talk about what both of them look like. I don't think there's a chicken or egg here, one before the other, but I think that we have to talk about both of them, and then kind of some of that healing can kind of start to take place in both of those areas. That would be my answer. Again, I would like to open that question up to every question, honestly.
Before we end, just one question online was, can you be a peer support working remotely?
Absolutely. We have actually created a telehealth platform just for that, with Straight Up Care for people to work remotely. What we saw was that there was a lot of barriers to what it looked like to be a peer support, specifically in South Dakota is where I started. And I was wondering, why aren't we getting peer support services into these rural areas? And we weren't seeing as much of that remote work as I felt like we needed. And with the support of the National Institutes of Health, we have implemented a telehealth app to get peer supports to be able to work remotely and be able to reach people. And it kind of helps with some of that anonymity too, being able to use an avatar, or being able to not have to go into a clinic or a space where people might stigmatize them for that too. So yes, the answer is yes.
Any last questions? If not, thank you very much, Dr. Moe.
Thank you so much. I'm
Reminder-
grateful for your time.
Reminder, use that survey link to evaluate this session, and then the next session will begin in 5 minutes right here. Same presenter, too.
Jacob, do I need to get into the other link or can I just stay on this one?